Microcytic hypochromic anemia. Introduction. Causes of which include iron deficiency, thalassemia trait and syndromes, alpha or beta, anemia of chronic disease, although this more usually causes a normochromic, normocytic anemia, sideroblastic anemia, lead poisoning. The commonest of these is iron deficiency, the causes of which are listed in Table 1. In clinical practice there may be more than one reason for the anemia and more than one cause of iron deficiency. History of the presenting problem. The first aim of the history should be to elicit possible causes of iron deficiency as outlined in Table 1. You should then move on to consider other possible causes of microcytic anemia, while also assessing the functional impact of anemia on the patient. Diet. The referral letter states that this woman's diet seems reasonable, but it is important to establish how many times a week, if any, she eats red meat, poultry, or fish, which are sources of relatively well-absorbed heme iron. Does she drink a lot of tea or eat a lot of chapatis? Both contain substances, tannins and phosphates and phytates, respectively, that inhibit intestinal iron absorption. NB. Dietary deficiency is very rarely, if ever, the sole cause of iron deficiency anemia. Bleeding. Ask specifically about symptoms of GI blood loss, which is a common cause of iron deficiency, particularly in men and postmenopausal women. Patients will normally volunteer obvious blood loss, but ask directly about piles. Those who have had them for years may have become so accustomed to them bleeding that they fail to mention them to you. Pursue a history that might indicate upper GI inflammation or ulceration. Ask directly, do you get indigestion or heartburn? Do you take anything for indigestion? Have you ever had a barium meal or endoscopy test? Take a careful history of the patient's bowel habit. Iron deficiency anemia with a change in bowel habit in a middle-aged or elderly patient means colonic malignancy until proved otherwise. Even though this patient is pregnant, ask about her menstrual cycle, as menorrhagia before becoming pregnant may have led to iron deficiency. Were her periods regular, and were they heavy? How many days did she bleed for, and how many pads did she have to use? Malabsorption. This is clearly not the likely diagnosis in this case, but abdominal symptoms of discomfort, bloating, excess wind or altered bowel habit should lead to further consideration of the possibility of malabsorption. In whites, but not Asians, celiac disease is common, prevalence about 1 in 300 people in Europe and North America, and often presents with iron deficiency anemia in the absence of obvious intestinal symptoms. Pregnancies. How many previous pregnancies has she had? Each of these will have been a drain on her body iron stores. Functional significance of anemia. The letter of referral states that the patient has been feeling tired and lethargic, but establish what is meant by this more precisely. What is the most exercise that she can do at the moment, and confirm what limits this activity. Compare this with her capacity before her pregnancy in a year or so ago to get a feel for the pace at which the anemia may have developed and to provide a baseline from which to judge her response to treatment. Other relevant past history. Aside from general screening questions, look at the causes of microcytosis. The history should be directed at establishing whether any of these factors are the cause, for this woman's anemia. As an Asian woman, the most obvious diagnosis to consider is that she may have a thalassemia syndrome. The patient, or relatives in routine clinical practice, may be able to provide you with this information. Ask directly, did you know that you were anemic? Has anyone told you this before? Do you know if anyone else in your family has anemia or thalassemia? Ascertaining the presence of a thalassemia syndrome in this patient is not only important in explaining the anemia but has implications regarding the risk of her child being born with thalassemia major. The male partner should be strongly encouraged to undergo testing if the woman is a thalassemia carrier. Plan for investigation and management. Explain to the woman that a number of blood tests are required to find the cause of this anemia and that there may be an inherited element. Blood count and film. The results of the FBC should be confirmed by examination of the blood film. In iron deficiency, the red cells will be hypochromic and microcytic, Fig 1, with pencil cells and the occasional target cell. The reticulocyte count will be low for the level of anemia, and the red cell count will be low. In beta thalassemia trait, the degree of anemia is often mild for the degree of microcytosis, e.g. HB10G/DL and MCV60FL, and the blood film shows target cells and hypochromic microcytes. In beta thalassemia major, the anemia is severe with poikilocytosis, basophilic stippling of the red cells, target cells, and nucleated red cells. Hemoglobin electrophoresis. In beta thalassemia trait, HbA2 is greater than 3.5%, but not always in the presence of iron deficiency. In beta thalassemia major, there may be no HbA, only HbF. Hb electrophoresis is normal in patients with alpha thalassemia. DNA analysis is required to make the diagnosis. If the patient proves to have thalassemia, then remember to recommend strongly that her partner be tested. Biochemistry. Serum iron, ferritin, and total iron binding capacity should be measured, as should B12 and folate for completeness. A low ferritin is very suggestive of iron deficiency, but beware, a normal or raised ferritin does not exclude iron deficiency, as it is an acute phase protein that may be raised in the presence of inflammation. Gastrointestinal studies. GI pathology seems unlikely to be the cause of anemia in this case, but GI studies are essential investigations in middle-aged or older people where cancer is a major cause of anemia. NB. Iron deficiency anemia with a change in bowel habit in a middle-aged or older patient means colonic malignancy until proved otherwise. Management. Although oral folic acid is recommended in pregnancy, obstetricians vary in their views on prophylactic iron because of side effects. In this case, commencing oral iron whilst laboratory tests are awaited is sensible. Plan to review the patient in a few weeks when the results will be available, and in the meantime liaise with the obstetricians. Further discussion. The recent UK antenatal screening program has resulted in all pregnant women being screened for iron deficiency or hemoglobinopathy in order to reduce the risk of fetal hemoglobinopathy. If maternal MCH is below 27 pg, then iron studies and Hb electrophoresis are performed. If these tests are negative, then DNA analysis is performed to determine the presence of alpha thalassemia, following written consent from the patient. Testing the woman's partner will give information about whether the baby can inherit problems from both parents. NB. If a pregnant woman has a thalassemia trait, then the father should be strongly encouraged to undergo testing. Homozygous, or compound heterozygous, forms of thalassemia can be devastating conditions for which counseling and prenatal testing should be offered.